Next, we have Michael Sun from Dartmouth College, and he'll be talking about learning body site-specific imagination-induced pain in 9 individuals. Okay.
All right. Yeah, thank you everyone for having me, and I don't think I could have asked for a better introduction to my topic than Xiaomin's last talk. So I want to present to everybody a recent research effort that I'm leading at Dartmouth, where we're creating personal pain connectome. So it sounds like a lot of people are very interested in just how subjective the experience of pain really is. So I want to caveat, I don't have any disclosures, but I do want to inform everybody that I'm a clinical psychologist by training, and admittedly early on in my training, I was pretty naive. I repeated this very cliched line, "I understand your pain, I know how you must feel," right? You see, I should have known that such a statement could never be valid, because being a psychologist was never really my first career aspiration. As a young child, I aspired, like every Asian boy growing up in Hollywood in the 90s, to be an action star, like Jackie Chan. But that magical illusion was quickly dispelled when I learned that while the job is really great when you're throwing punches, you also have to take punches too. And just imagining myself being punched in the face ensured that that would never be a sustainable career option. But now that I'm an adult, while I've enjoyed his film performances over the years, I almost find it more entertaining to know that Jackie, him being the world's most uninsurable man, experiences a paralyzing degree of pain when it comes to injections, probably more pain than you and I would experience. As Xiaomin had talked about earlier, what's been documented for decades is that the nociceptive aspect of pain is pretty simple. A nauseous stimulus is transduced into a signal that is transmitted through the dorsal horn of the spinal cord, travels up the spinothalamic tract into the thalamus, and then this gets projected into the cortical surface. And it's here, the cortical surface, where the phenomenon of pain emerges into perception. This perception is implemented in such areas like primary and secondary somatosensory cortex, insula, and anterior cingulate. And it's highly variable and highly personal. It probably invokes some cognitive model, like it hurts because I just got punched, for example. It probably produces predictive representations, like it's probably going to hurt again if I get punched again. And it's emotionally aversive in content, like I don't like the feeling of being punched. But since it's pretty obvious that Jackie and I have very different feelings about getting punched in the face, given that he makes millions of dollars every year doing that, and our personal relationship with pain is likely fueled by one's personal learning history, situational expectations, and unique motivations and emotional faculties. So imagining oneself doing anything such as being in pain is proposed to be an information flow reversal from cortex to early sensory areas. This process is expected to reproduce some facsimile of the true experience, but one that's likely to be weaker, less detailed, and more cognitively controlled. And also some part of the cortex must also implement something called a source attribution function. This means that we should be easily able to disentangle an internally generated stimulus from an external one. Otherwise, we just think that we're being punched all the time, for example. Previous work has shown weak but clear recapitulation of regional activation overlap between imagined and real pain. And existing work so far has just left it at these regional activation inferences, and they don't go beyond this. So we asked the question, what happens in the brain when we imagine pain? How similarly does it work? And how unique is it to the person? So in other words, can we uncover subject-specific activation patterns of experienced pain, and does imagined pain patterns, do they resemble them? So this project, led at Dartmouth, titled the Warmth, Anticipation, Sensation, Aversion Body Part Imaging Study, is lovingly called WASABI for short. We gathered 9 subjects and had them undergo a deep personal brain phenotyping through fMRI while they're experiencing thermal pain, also when they're instructed to imagine pain. And then we also use a warm stimulation as a single subject control across 8 different body sites. This effort meant that each subject went through almost 100 hours of suffering in the scanner. And so before you call me a psychopath, just know that I'm also one of the said subjects, so I know exactly how they felt. First, we had each subject calibrate the degree of pain that they could tolerate at each of the 8 body sites using an ascending method of limits procedure. And then they came in for repeated fMRI scan days, which featured about 4 scan runs with 40 back-to-back trials of either getting real thermal stimulation, being instructed to imagine a thermal stimulation, or getting a warm, non-painful stimulation or a rest. And then this was ended with some self-report ratings at the end. First off, the calibration data shows that subjects' self-report pain ratings were equitable across body sites, which indicates calibration success. But as expected, the detection sensitivity and pain tolerance of temperatures that were calibrated varied substantially across subjects. And maybe for some people's interest, the face happens to be the body site that's most tolerant of heat, so perhaps it wouldn't be the worst thing in the world to get punched in the face as opposed to another body site. After subjects underwent fMRI scanning, we used 3 analysis approaches to take the most advantage of this design. First off, with univariate activation maps, you can see experienced pain contrast maps on the left and imagined pain contrast maps on the right. You see the group level maps next to the 9 individual subject maps. You can see quite a lot of variability within each subject. And then we also correlated each of the images with neurosynth word associations. And there's, even though there's quite a lot of difference between the group maps, there's a lot of overlapping regional areas that we would expect, including thalamus, SMA, and the superior premotor cortex. We also ran these images through well-validated multivoxel pain signatures, the neurological pain signature and the stimulus intensity independent pain signature, the top one being reputedly more of a nociceptive signature, and the bottom one being more of an emotional cognitive pain signature. And you can see that here, you can see that many subjects are able to fool this emotional cognitive pain signature just with imagination. Correlating the maps with Hansen neurotransmitter maps shows that actually the experienced and imagined pain conditions share a similar profile of activations involving regions dense in neurotransmitters like dopamine and acetylcholine, and it's the imagined condition that simply shows an overall blunted response. So they're actually quite similar. We also took this pattern similarity approach a step further by doing a precision functional mapping. We took 5 body site replicates for each subject and trained a binary support vector machine to classify hot from warm images with 5-fold cross-validation. We trained on 4 replicates and tested not only on the left-out replicate, but also all other images from all other conditions and body sites. And then we did this for every subparcel of the brain using the CanLab 2024 Atlas. Using this method, we're able to identify regions of the brain that are consistently nociceptive, that's shown in pink. And then red is not only nociceptive, but also body site selective. But even if these regions are body site selective in most subjects, the subject level maps shows a great deal of variability in how the site selectivity is configured. And importantly, even regions that are more reputedly nociceptive and the nociceptive chain, they're also body site selective all along the chain as well, from thalamus S1 to S2 and insula. Really importantly to notice here, though, is that the imagination condition does not recapitulate this nociceptive body site selective pattern in any of these regions. So since our most extreme attempt at equating experience with imagined pain failed, we took a step back and took a representational similarity approach. And with this approach, you can see that for the whole brain, we can see at the group level, voxel-wise spatial correlations, and subject level showing a very, very similar structural pattern. You can immediately see that there's a clear body site geometry at both the group and subject levels. And then there's also a clear within-condition similarity, such that hot images look like hot images, imagined images look like imagined images. But importantly, when we test across conditions, we can see that the hot and imagine similarity is actually significantly greater than the hot and warm sensory condition similarity. And that was true for all subjects. We can replicate this procedure through the entire brain and show that every single region of the brain actually shows is to the left of the identity line, which means that hot and imagined patterns are more similar to each other than sensory patterns, hot and warm. And with the Bonferroni correction, we can show that it's the regions that are very transmodal in the frontal cortex, cerebellum, and hippocampus that are, in previous literature, responsible for the source attribution function that sees the highest correlations between hot and imagined pain. So to conclude, classic debates on imagination of imagery asserts that imagination might be depictive on one hand, where it replicates the original sensory experience, or propositional in that it's more abstract, more verbal, linguistic. Our fine-grained pattern analysis shows that in all 9 subjects, this distinction is not necessary. Every region of the brain shows some similarity between the two. And we saw that, as expected, experienced pain produces robust brain activity that's separate from warm, it's body site specific, and it's conserved in a way across individuals. So at least one clinician now changes the way he speaks with his patients. I'd like to give many thanks to NIH, who funded this work, as well as the Dartmouth Hitchcock Foundation, and my colleagues at the Ken Lab at Dartmouth. Please visit poster number 2045 to get more information about this project if you're curious.
Thank you very much. We have, we have one brief question.
Oh, yeah.
If it's possible. How did you validate participants' imagining pain?
Great question. So we did a discrimination analysis. Well, the first thing we did was after every scan, we would ask them if they fell asleep, and if they were able to successfully imagine pain. And then we also ran the images through support vector machine discrimination analysis to show that all the imagination condition images were highly discriminable from other conditions, and they were the ICC-2K for imagination is above 92%. So yeah.
Thank you very much. Again, let's thank Michael again,
Yeah.
and invite our next speaker. Next, we have Leju from McGill University in Montreal, Canada, with chronotypes, subtypes explain unique behavioral profiles and health associations.